So let us do a small surgery topic. We have large intestine. So you have large intestine, you have an obstruction of the colon, you have diverticular diseases of the colon and ulcerative colitis. Anatomy. So from the end of the ileum to the end of the rectum is the large intestine. Then the right colon, cecum, ascending colon, hepatic flexure, proximal transverse colon, left colon, distal transverse colon, splenic flexure, descending colon, sigmoid and rectosigmoid are all the parts. And large intestine anatomy, you have ascending and descending colons which are fixed in the retroperitoneal space. Transverse and sigmoid colon are suspended by their mesocolons. There are four layers. You have mucosa, submucosa, muscularis, and the serosa. So large intestine anatomy, rectum is 12 to 15 centimeter in length. Tinea coli are not apparent in the distal to the rectosigmoid junction, and the upper rectal rectum posteriorly is retroperitoneal, and the anterior peritoneal reflection is 6 to 8 centimeter above the anal verge. So large intestine physiology, you have absorption, secretion, motility, and intraluminal digestion. Then X-ray, if you take, you see plain films, you get a gas distribution, and obstructing colon cancer may demonstrate dilatation of the proximal colon, and airfield level will be there, which is a Cloblier sign, airfield level. Then barium enema, you can see diverticulum sign cancers. Double contrast barium enema, you have barium and air in circulation. It is more sensitive for small lesions. So the barium enema procedure, the patient has to lie on an X-ray table, and the barium is put into the rectum and flows through the colon. X-rays are taken and to look for abnormal areas. So large intestine CT scan. CT is useful for the diagnosis of masses, appendicitis, diverticulitis, and all. Then you can do CT cystogram, which is virtual colonoscopy, CT cologram, 3D reconstruction of the distended colon can be done. MRI for better cancer staging, and PET scan is positive emission topography is 95% sensitive and 95 specific, 98% specific for colonic cancer. So large intestine, you have fibro-optical colonoscopy. The direct vision of the entire colon, biopsy and brushing can be done. And diagnostic colonoscopy and therapeutic colonoscopy can be done where it is excision of polyps, bleeding control, foreign body removal, volvulus detorsion, and structural dilatation. So large intestine, fibro-optical colonoscopy. The colonoscope is inserted through the rectum into the colon, and a colonoscope is a thin tube-like instrument with a light and lens for viewing. It may also have tools to remove polyps or tissue samples. So contraindications, you have fulminant colitis, which is unsuspected perforation, which is a relative contraindication. Fulminant colitis is an absolute contraindication. And complication, you have perforation in 0.1 to 0.2% and bleeding in 0.2% of the cases. This is large intestine fibro-optical colonoscopy, contraindicated fulminant colitis and suspected perforations. Then you have large intestine. Other methods, you have proctosigmoidoscope and flexible sigmoidoscope, 85 centimeter length, and angiography to detect bleeding sites. Just a second. Fibro-optical. Okay. The sigmoidoscope, a thin ligator tube is inserted through the anus and the rectum and into the lower part of the colon to look for abnormal areas. So then you have obstruction of the large intestine. 15% of all intestinal obstruction are caused by carcinoma volvulus. No, 15% of all intestinal obstruction is large intestine, and most common is cancer, 65%, volvulus is 5%, diverticular disease is 20%, inflammatory diseases, benign tumors, and fecal infection is remaining. Obstruction to the large intestine, you have constipation, dilatation, distension, tenderness, abdominal pain, nausea, vomiting is laid, and X-ray findings will be there. Peristaltic waves may be seen if abnormal wall is thin, and high-pitched metallic tinkles, rushes, and gurgles may be heard, and tenderness and papillomas can be seen. This is one of the colon. Obstruction to the large intestine. So the distended colon creates a picture frame outlining abdominal abdominal cavity. Obstruction can distinguish colon from the small intestine. Contrast enema can be given, very must not be given orally if obstruction is suspected. CT is the most useful test, giving give information about location and etiology. So obstruction of large intestine in differential diagnosis in small intestine versus large intestine. Small intestine, it is slow in onset, it is less painful. It may not cause vomiting or late vomiting, and elderly patient with no surgery or prior attacks or obstruction often have carcinoma. Large intestine is slow in onset, less pain, may not cause vomiting or late vomiting. It may cause elderly patient will have no surgery or prior attacks of obstruction, often have carcinoma. Then obstruction or large intestinal differential diagnosis, you have it may be due to paralytic areas, a result of peritonitis and trauma to the back or pelvis. There will be no clumping. The abdomen is silent. Enema excludes obstruction. Then obstruction of the large intestine differential diagnosis, it can be a pseudo obstruction, which is Ogilvie's syndrome, where the colon distension in the absence of mechanical reason will be there. Extra intestinal illness, you have renal, cardiac, respiratory trauma, vertebral fracture, X-ray enema and nasogastric tube suction, colon tubing and nasostigmine is effective. Massive cervical dilatation is a hallmark of Ogilvie syndrome, which with dilatation of other parts of the colon. So you have obstruction of the large intestine differential diagnosis, pseudo obstruction Ogilvie syndrome. Yeah. Okay. Then obstruction of the large intestine treatment. No, Ogilvie syndrome. Hallmark is massive cervical dilatation. Cecum colorectal, cecum dilatation. So obstruction of the large intestine treatment. In case of obstruction, operative treatment is required. Resection with primary anastomosis can be done. Resection with intro or colostomy, ileostoma, cecostoma, transverse stoma, and sigmoidostoma. It may be temporary or final. So no resection can be associated with bypass. You can do it with bypass. Resection with primary anastomosis, resection with intro or colostomy, temporary or final, and no resection with bypass. Okay. So first you have resection and colonoscopy. You resect it. Colonoscopy bag is made. So the LD bowel intestinal obstruction can be resected, and the LD bowel is stitched to the abdominal wall, colostomy, and the bag is placed. Then dissection with transverse with primary anastomosis. You can resect and you can pull it to do primary anastomosis. Staging of cancer, it can be from 0 to 4, and stage 0 is carcinoma in situ. Abnormal cells are found in the innermost lining of the colon. These are abnormal. So they may become cancer and spread to nearby tissue. Then stage 1 is formed and spread beyond the innermost layer of the colon wall to the middle layers, and stage 2 is 2A is cancer has spread beyond the middle tissue towards the colon wall or has spread to nearby transverse nearby organs and or through the peritoneum. Then stage 3 is innermost tissue to the middle layers and spread to as many as 3 lymph nodes. And stage 3B is 3 nearby lymph nodes and beyond the middle tissue of the colon wall or nearby tissue around the colon or rectum, or beyond the colon wall into the nearby organs and or through the peritoneum. Then staging of colon cancer 3C is spread to 4 or more nearby lymph nodes and spread beyond the middle tissue layers or nearby tissue along the colon or rectum or near peritoneum. Stage 3 cancer is sometimes called as Duke C colon cancer. Stage 4 may spread to lymph nodes and spread to other part of the body such as lungs and liver. Metastatic. Then cancer of large intestine, 5 to 15 years of silent growth are required before cancer reaches symptom producing size. Routine screening since the age of 5 once every 10 years is recommended. Then cancer of large intestine, you have right colon, unexplained weakness, anemia, cold blood in feces, dyspeptic symptoms, persistent right abdominal discomfort, palpable abdominal mass, X-ray, colonoscopy can be done. And the indicate large intestine cancer. Cancer of large intestine, left colon, change in the bowel habits, cross blood in the stool, obstructive symptoms, X-ray and colonoscopy or sigmoidoscopy can be done. The entire thing is removed and anastomosis can be done in the image. Okay. Then cancer of the large intestine. Colonoscopy examines the entire length of the colon. Sigmoidoscopy examines only the lower third. Then rectal bleeding, alteration in the bowel, habits, sensation of incomplete evacuation, intrarectal pelvic sigmoidoscopy are all signs from rectum cancer. Then cancers of the large intestine. You have ways of cancer spreading. You have direct excision, goes circumferentially and completely encircles the ball before it is diagnosed. Eventualitis is hepatic, lungs, and ovary. Regional lymph nodes are spread most commonly. Transperitoneal seeding can be done which expands when it extends to the serosa, and intraluminal MTS swept along the fecal current can be seen. Then cancer of the large intestine diagnosis, laboratory finding, most familiar marker for cancer of bowel, ASCEA, carcinoembryonic antigen, and barium can be done. Then cancers of the large intestine treatment, you have wide resection of the colon with regional lymphatics. Resection indicates even in distant MTS to avoid obstruction and bleeding. The extent of resection of the colon for cancers in various locations and in methods for restoration of continuity can be done. So treatment options for colon cancer stage 0 may include the following types of surgery: local excision or simple polypectomy, resection or anastomosis. This is done when the tumor is too large to remove by local excision. In treatment of stage 1 to 2, stage 1 is usually reconstruction or anastomosis, stage 2 is reconstruction or anastomosis. Clinical trials of chemotherapy, radiation therapy, or biogenic therapy after surgery can be done. Then in treatment for stage 2 cancers, you have left hemicolectomy, sigmoidotomy. Then you can give chemotherapy, radiation therapy. Then as a stage 4 colon cancer, you have resection or anastomosis, surgery to remove parts of the other organ. Then radiation can be given, chemotherapy, local excision, chemotherapy, radiofrequency, and chemoembolization can be done. Then radiofrequency ablation, it can be used for a special probe with tiny electrodes that kill cancer cells. Sometimes the probe is inserted directly through the skin and only local anesthesia is needed. In other cases, the probe is inserted through an incision in the abdomen. This is done in the hospital with general anesthesia. Cryosurgery is another new technique that can destroy tumors in various sites. Abnormal tissue using sub-zero destruction using sub-zero temperature. Initial results in properly selected patient with unresectable are equal to resection. Okay, that is saying it's good. Cryotherapy involves placement of stainless steel rod into the center of tumor. Liquid nitrogen is applied through the end of this device. And then chemotherapy and chemoembolization before or after this thing. So, systemic or regional chemotherapy can be given, and chemoembolization, it is a palliative treatment for primary or metastasized liver cancer. Chemoembolization, 3 chemotherapy drugs are injected into the artery that supplies the blood to the tumor in the liver. Artery is then blocked off, embolized with a mixture of oil and tiny particles, and this procedure is accompanied with a few things. The tumor becomes deprived of oxygen and nutrition, and once the blood supply is blocked, because these drugs are injected directly at the tumor site, the dosage is 20 to 200 times greater than that achieved with standard chemotherapy. Because the artery is blocked and no blood washes through the tumor, as a result, the drugs stay in the tumor for a longer time. There is a decrease in side effects because of the drugs are dropped in the liver instead of circulating throughout the body. Radiation therapy is also can be done. Radiation therapy is high energy X-rays or other types of radiation targets rapidly divide cell into cancer cells, prevent cell division and replication of DNA. You have external machine and you have internal machine. IV radiation therapy and machine radiation therapy. Directly into any other things. Radiation towards the cancer is machine outside. All of this depends on this thing. Chemoembolization is reblock of the hepatic artery. And that's all for this small topic in large intestine. I'll catch you guys in another video. So thank you.